Good afternoon, everyone. So today, please welcome everyone to Let's Learn for COVID-19 India response. Today we are organizing at Health Intervention and Technology Assessment Program. We'd like to go through some of the housekeeping rules to make sure we smoothen our webinar for everyone. So the first, please use hand raising button before asking questions, and our admin will consolidate and allow you to use your video. And the second one will be you can use a chat box if you prefer using text. That will be great. Yeah, also. Okay. So okay. First, please let us introduce to Dr. Suwit for the first introduction.
Welcome everyone. My name is Suwit Wibulpolprasert and would like to introduce you to our webinar today. And I would like to welcome everyone again. We come from many countries to listen to the lesson learned from India today from our distinguished speakers. Today we are going to spend 1.5 hours listening and discussion about the lesson learned from India. And first, I would like to introduce our two speakers. Dr. Suwit Wibulpolprasert from the Ministry of Public Health. Dr. Suwit Wibulpolprasert is the public health specialist, administrator, and policy advocate. He used to be the director of a rural hospital in Thailand during 1977 to 1985. And he is the director of the Food and Drug Administration Technical Division, director of the Bureau of Health Policy and Plan, assistant permanent secretary and deputy permanent secretary of the Ministry of Public Health. He is vice chair of the International Health Policy Program Foundations. And the last government position for him is the senior advisor in disease control to the Thai Ministry of Public Health. From December 2015, he is an advisor to the Ministry of Public Health on global health. And currently, he is the member of the National Health Security Board, Health System Research Institute Board, and the National Research and Innovation Policy Council. I would like Professor Suwit is going to be chair of this section, and we will listen from his perspective in lesson learned from India. Next, please. Our speaker is Professor Gagandeep Kang from Christian Medical College, Vellore, India. Professor Kang is the professor in the Division of Gastrointestinal Science at the Christian Medical College. He is the chair of the Immunization Technical Advisory Groups for the World Health Organization Southeast Asian region. He is the first female fellow of the Royal Society and an independent director of Hillman Laboratories, a joint project by MSD and the Wellcome Trust aimed at developing effective and affordable vaccine for developing countries. She is the distinguished researcher and policy advocate for vaccine development in developing countries. I would like to welcome both speakers for this section. And I would like to ask Dr. Suwit to give his opening remarks. Thank you very much.
Thank you so much, Dr. Suwit, and welcome everyone. Good afternoon, Professor Gagandeep Kang. Madam, are you okay? Are you ready?
I'm ready. Thank you very much for the welcome, Dr. Suwit.
I'm so glad to see your so-called Indian smile. And now I am sure that this afternoon session would be a very stimulating one, learning from someone who have real first-hand experience on the situation of India. We have just seen a report from UK that, about how UK responds. In conclusion, the report said initially they did wrong, but later on they did right. That's what there are other details, but this is a simple conclusion. And some of my colleagues say this is in the reverse to Thailand. Initially we are right, and then later on we are wrong. I'm not sure about India. We should hear from Dr. Kang. Okay, and today I would like it to be a very informal session to learn from India, and I'm sure we can share some of the experience to Professor Kang as well. There's nothing right or wrong when you tackle with the situation that you have inadequate knowledge, and also the situation change all the time. So we are not saying anyone doing right or wrong, but we are going to talk about what has happened and what have we learned and how can do better. How can we do better? Okay. I'm 68 years old. My last 68 years, this is the first and biggest pandemic I have ever faced, as compared to H5N1 that we faced in 2004, SARS that we faced in 2003. This is like, this pandemic, those two are like kindergarten, as compared to this one is like a PhD thesis for us. So we're exploring something that we are not very fully informed, okay? I would like to put some ground rule on this. First, we'll hear from Professor Kang first. I'll see how things go. She has 4 parts of presentation. I saw her PowerPoint slide, very, very interesting. And from the PowerPoint, it's not very many PowerPoint, which is quite surprise for me. When I hear an Indian make presentation for 15 minutes, I may have seen 70 slides, but I saw I think not less than 20 slides with very, very important information and conclusion within the slide. So I'll see whether how things go. And audience, please feel free to send your question in, okay? To be easy for us to manage. One audience, please send one question, one most important question in the first round, okay? And we'll have a team of 3 very able and young fellows to give the score to each question. The highest score will be used to ask Professor Kang first, okay? So you can send in your question anytime until we are ready, until I see that this is the time to put the question. It may be in the middle, it may be whenever. I'm sure Professor Kang, I learned from many friends, not many, a few friends in India that Professor Kang is an exceptional Indian scholar. She responds to questions very straightforwardly, knowledgeable, and she's ready to speak. She is not a diplomat or civil servants. We have to be very diplomatic. This is the real good chance for us. Okay, so please send in questions through the chat box, and we have 3 able fellows who give you the score. I hope that HITAF can provide some, some gifts to those who have highest score. For example, invite them for the fourth or third dose of COVID vaccine to receive the fourth dose of COVID vaccine. I myself has only the second dose. And they said, you have enough. You don't need the third one. But the most important thing is to keep vigilant, distancing, mask, and hand washing. These are the three most important ones. At the same time, I am so much eager to November 1, when our government decided to open up the country for foreigners to travel in without having to be quarantined. This is quite interesting. Learning from Phuket Sandbox, now National Sandbox, and see what would happen. Okay, now may I invite Professor Kang to start her presentation. Professor Kang, I hope you don't mind if I stop you anytime with some question.
Absolutely, anytime. But you're a very hard act to follow, Dr. Suwit.
Wow, thank you, thank you. Please go ahead. You can share the slide.
Yes, I think they're going to be sharing the slides from HITAF.
Okay.
So I have mine and I can share them if you like. Should I go ahead and share?
We are sharing, Professor Kang. We'll share.
Okay, sure. So it's such a pleasure to be with you here today and to talk to you about what's been happening in India. Dr. Suwit pointed out that, Thailand did well initially, and then you were a little more worried about what was happening. In India, I think it's been a mix of good and bad throughout. What has worked, what has not worked. And as with every other country, we continue to learn. Now, if we look at the graph that is shown here, that shows the two waves in India. The first wave reached almost 100,000 cases, and the second wave crossed 400,000 cases being reported a day. And when we were in that, we thought that the 100,000 was scary, but it was nothing compared to what happened when the numbers started climbing so quickly in the second wave. We now know that the bulk of the second wave was driven by the fact that we had a much more infectious variant, the Delta variant. And India was the first place that saw the Delta variant. It was actually detected in September of last year, but it didn't really take off until February of this year. There were many reasons that drove that tipping point where it became exponential. Some of those had to do with behaviors of people and populations, and others had to do with the characteristics of the virus itself. Where we are today is that we are in a much, much better situation. We are reporting under 20,000 cases a day. And of those 20,000 cases a day, about half of them come from one southern Indian state, which has excellent reporting systems. But overall, we are in a situation that is nothing like what we had 6 months ago. Next slide, please. Now, if we look at the number of cumulative confirmed cases, we've had about 34 million cases reported. And in terms of numbers of cases, we are second only to the US, which has reported 44 million cases. If you look at the cumulative graph, you can see that we slowed towards the beginning of the year, and then the second wave drove a very rapid increase in cases. The next slide, please. So that was cases. Now we come to deaths, and the pattern of deaths has pretty much been the same pattern as the cases that have been reported, but instead of the hundreds of thousands, the reports of deaths reached a maximum of just over 4,000 deaths at any given time. And the odd spikes that you see there is when reconciliation of data happened, when states submitted data late and it needed to be combined with national numbers. Now, if we look at deaths, we are actually not number 2 in deaths. We are number 3 in the absolute number of deaths, because it's the US, Brazil, and then India. The US has over 700,000, Brazil has about 600,000, and India has 450,000 deaths. If we look at the rates of death by the population, then we see a different picture. In this past week, our World in Data tells us that if we look at cumulative confirmed COVID-19 deaths per million people, then Peru, with 5,900, far outstrips India at 323. And India is not that different from Thailand at 250. However, we have to remember that these are official reports of death, and there is a difference in different countries. Next slide, please. India's real numbers are truly unknown. If you look at the horrific pictures that were in the media, it was clear that most deaths that were happening in India, particularly in April and May of this year, were not being picked up in the official records. So there have been a number of people who have tried to figure out what the real number of deaths is. And the figure varies anywhere from 5 to 10 times the actually reported number. So this figure that was published in Nature at the time when the official toll was 425,000, there was also an estimate that was made based on excess deaths in the National Household Survey that showed that we had almost 5 million excess deaths being reported during the past year. If we look at more granular sources of data in specific cities, what's shown in the blue bars is for different cities, the official count of COVID-19 deaths. And then we have a special protocol for the cremation of people who have been COVID-19 positive. And if you look at the red bars of cremations of COVID-19 victims in defined cities in the country, you can see that there is a huge difference. In Bhopal, a 24-time higher rate of cremations compared to the official figures, and it varies by different areas in the country. Next slide, please. Now, coming to infections, when you look at cases that are reported depend on the tests that are done. You do more testing, you will identify more cases, and you would be able to classify more deaths as COVID-19 deaths. But it really is sero surveys that give us better information on the infections that are happening in the country. And very early on, we had surveys that were conducted in India. And fortunately for us, we have had 4 nationwide sero surveys that have used the same methodology in survey after survey. There are problems. They used different tests at different times. They excluded what were called containment zones. But in general, we have a picture of what snapshots taken at different times for infections in India. The first sero survey was May to June 2020. And in that sero survey, we had 0.7% of the population infected. Now, each of these sero surveys is between 25,000 and 30,000 individuals. When a sero survey was done after the lockdown opened up, which started from June onwards, from August to September in sero survey 2, it became 6.6%. So a tenfold increase between May to August. And if there were studies that were done in specific locations, then you could look at urban slums, urban areas, non-slum populations, and rural areas. And obviously, where there was a much denser population, you had much higher rates of seropositivity. So in the second sero survey, 6.6% for the whole population, but 15% positivity in urban slum areas. And then if you go to the third sero survey, that 6.6% climbed to 21%. And this was a survey that was done from December to January of 2020, 2021. So you can look at differences by gender, not that different. The denseness of the population, that still holds. And healthcare workers slightly, but not very much higher than the general population. The next slide, please. You also had other sero surveys that were done in the country, and these were sero surveys that used convenient samples, either the city that you were located in, or in the case of the map with the green, yellow, and red dots, these are laboratories, research laboratories, where they were able to recruit the staff and their families and test them. And what they saw there was a variation where if you looked at at cities, larger cities, then you had higher rates of positivity. For example, Ghaziabad had 13% just outside of Delhi, and Delhi had 14% positivity. And Thiruvananthapuram in southern India had only 1% positivity. So there were a variation in location, variation in the types of populations that were sampled, but we actually have a lot of serology data from India that tells us who was getting infected. And some cities repeated sero surveys for themselves, and that was very informative as well. Next slide, please. And then we had the fourth sero survey, which was done in June and July of 2021, which was after that sharp Delta wave that we had seen. And here, 67% of people had been infected or vaccinated. This was a time when vaccine coverage with a single dose of vaccine was less than 10%. So most of the 67% positivity was actually coming from infection. And if you looked across the different states in the country, there was a huge variation, with Madhya Pradesh at 79% of the population and Kerala at 44%. And Kerala is the state that has subsequently been reporting the greatest number of cases. I think in the first section, the next slide is my last one. So to talk about the government response, India declared COVID-19 as a disaster on the 14th of March. And the reason for doing that is under the National Disaster Management Act, if you declare a natural disaster, then the states can spend their disaster relief funds. But following that, very quickly, a lockdown was announced on 25th of March when we had less than 500 cases. And this was among the most stringent lockdowns in the world. I can tell you how stringent it was, because we were doing research studies that required collections of blood samples from the population. And these were studies we had invested 1.5 years of effort in, so we didn't want to lose the study. And if your study participants were located in a containment zone, the police that were guarding the containment zone would beat up our field workers. It was essentially, the lockdown was converted into not a public health problem, but a law and order problem, where breaking lockdown was considered a crime. There was also the establishment of multiple committees and empowered groups, and these consisted mostly of bureaucrats and not very many scientists. And if there were scientists, they were not really necessarily experts in communicable disease control. The states also established their expert committees, and there were very good committees in some states and no committees or terrible committees in other states. The medical response in the first wave taught us a lot for the second wave. Many of the private hospitals were notified as COVID hospitals. Many of the government hospitals became COVID hospitals. And there was an increase in the number of beds that were made available, ventilator beds, ICU beds. The quality varied in terms of what was labeled a ventilator bed and what was the kind of ventilators and the staff that were available. But at least metrics were established for what was considered sufficient to be able to manage a surge in cases. There was a lot of guidance that was developed. The guidance had some quite irrational recommendations. These included many traditional medicines. It also included hydroxychloroquine and ivermectin. And in fact, one of the failures of the system was that hydroxychloroquine and ivermectin continued to be recommended as potential treatments until about a month ago, when the revision was finally made to remove these. In terms of the public health response, if we look at surveillance, well, the first case in India was on the 30th of January, and until the 15th of March, no private laboratory was allowed to test. And even when they were allowed to test, they were asked to send all of their samples, positive or negative, to the government laboratories for confirmation. And this, when we know that the quality of the work that is done in accredited private laboratories is generally better than is done at government facilities. There was very deep centralization. There was very deep data control. Even today, if you get a test done, you have to fill out a 4-page form. Most of the data from those forms is not available. And the little that I have seen is that it's unusable. There was also COVID care camps that were set up. And those could be tented camps. They were converted buildings. And again, the quality varied very much because at least initially, anybody who tested positive had to be isolated outside of their homes. And many people found the conditions at these COVID care camps so terrible that they ran away from them. The socio-economic response also varied by state. Kerala, for example, which is a state with good public health infrastructure, had separate camps for migrants during the lockdown and provided food packages that were very well constructed, a strong volunteer system. Whereas in other states, there was no such requirement. And in fact, we had the scenes of millions of migrants marching across the country to their homes. And fortunately for us, the migrations happened at a time when there wasn't a lot of infection around. So they weren't carrying infection to different parts of the country. There was a very different situation during the second wave or prior to the second wave, where you had people who traveled for religious festivals, where testing was inadequate, and those events then acted as super spreaders, where when you had people returning from pilgrimage, and up to 70% of returning pilgrims were testing positive, so resulting in seeding of infection across the country. There's also recently been the decision that compensation will be paid for people who, two families who had family members who died because of COVID-19. And this is a consequence of our legal system where if it's a disaster, compensation has to be paid. The political response varied a lot. Politicians, some of them were front and center of their constituencies, helping people. In others, because elections came by, they modeled very poor behavior by encouraging people to come to election rallies. And last year, for the first time, we had a health-related incentive to vote for a party, and this was the promise of free vaccines. So it's complicated to sum up everything about India in a short time, but I will stop here with the first part of the presentation, and I'd be happy to take questions.
Thank you so much, Professor Kang. Very exciting, and you conclude excellently in very short time. While I'm waiting for the question from the three fellows, we have seen question in the chat box already, so they'll score for me. I would like to ask you a few questions first, like a startup, a warm-up. Professor Kang, do you think that there will be the third wave, big third wave in India?
Yeah.
Taking into account 67% of the people already seropositive. This is very important question to us because we control ourselves very well until India has the first wave and then spread to Bangladesh. Then we knew that soon it will come to Thailand because from Bangladesh, it come to Myanmar. And we have several, 3-4 millions migrant workers from Myanmar. It's very difficult to escape that. And it came into Thailand about 6 months after the Indian first wave. Now you have the second very big wave. And we follow you very closely. If you have the third one, we have to prepare well. So please, with this very high seropositive, do you think that the fourth wave will come? And if the data is correct, 67% of the population means about 900 million people, more than 900 million people have already been infected, while the report is only 34 million. It's almost 30 times different. This is quite scary. While India tested about 420,000 tests per million population, and Thailand tests 3 times less, 130,000 tests per million population. So we are testing 3 times less than India for RT-PCR, while India has 34 million, and the fact is 900 million. So in our case, it may be more than 30 times more than we reported of our report of 1.7 million. What do you think about this, Professor Kang?
So let's look at, will there be a third wave as the first question? And I think that on top of the 67% seropositivity, we also have to recognize that India has given out almost 1 billion doses of vaccine now. So Kerala, the state which had 44% seropositivity in June, just had another sero survey done. And there we are finding 85% seropositivity in adults and 40% seropositivity in children. So that just indicates that a lot of the experience of the last 4 months with both infection and vaccination will have pushed the 67% in India higher now. How much it is until we have another sero survey, we won't know. So then how many susceptible people are left? With a population that is close to 1.4 billion, I think we probably have somewhere around 200 to 250 million that continue to be susceptible, and this includes the total population, which is children. Now, the 250 million odd are distributed around the country. So I don't think that we are going to have the kind of widespread transmission and increases in cases that we saw during the second wave. What we will see is introductions into pockets, flare-ups of cases as transmission occurs within families, within population groups that are continuing to be susceptible, but we won't see the large increase in cases that we saw during the second wave. Of course, if we get a variant that is completely able to escape the immune response and can transmit really easily, then we have the possibility of a third wave. But we've also strengthened our genomic surveillance. And I think now we are at a stage where the surveillance could do better, but it's not doing a bad job of turning around results for sequencing. So maybe, the average is still about 3 weeks to a month to turn around surveillance data. If we can get it down to a week or 2, that would be great. But I don't think we will see a third wave like we've seen before. Now, will the same situation happen in Thailand, or, will you have a propagation that occurs across Southeast Asia? It depends on the proportion of your population that is susceptible. There is virus here. The virus is not going anywhere. It's not going to, because it affected us so badly in the past, and because we have high vaccination rates, I don't think we will have to deal with the third wave that's as bad as the second wave we had. But that protection in other populations can only come from population exposure to infection or high rates of vaccination. And that's what Thailand needs to be looking at.
Thank you, Dr. Kang. Very clear. While I'm waiting for the question from the 3 fellows, I see from the chat box a few very interesting questions. But at this stage, before you go to the second, third, and fourth presentation, may I ask Dr. Renu to pose her question first? To mention her question. Dr. Renu Kang from the WHO country office in Thailand. She knows our situation quite well. Dr. Renu, please.
Thank you, Dr. Suwit, for the opportunity. And hello, Dr. Kang. So nice to hear from you and always inspiring. And thank you for saying it as it is. Your presentation is very clear and thought-provoking. I had 2 questions. One is, why did India, with all its abilities, not develop capacity for testing? In between January and March of 2020, it was kind of, there was hardly any preparation other than screening, but at the airports, but there was really no capacity developed for testing. So that's one question. And the second one, which I'm sure many of my colleagues here in Thailand would also like to know, how to, this is a pandemic where the there's been a lot of political sort of interference. how can we use, the political capital to strengthen any future preparedness and response rather than interfere with it? Thank you so much.
Thank you very much for those questions, Renu. I mean, it was a mess last year when it came to testing. There were a lot of us arguing that one of the first things for an infectious disease is to have the ability to diagnose it distributed as widely as possible. And instead, what we had was a very command and control structure where you had to practically get permission to do a test, that you weren't allowed to test in many situations. And the reason for that was that the government wanted to control the narrative on how many cases. Even if you look at the WHO website, which classified countries into the levels of transmission that they had, India refused to admit that the disease was spreading in the population, no community transmission. We went through the entire first year of the pandemic claiming that we had only clusters of cases. And that's really about controlling the narrative. I thought it was very interesting that the response was very different from H1N1 and for SARS-CoV-2. For H1N1, there was a rapid attempt to involve private laboratories, recognizing that they actually have a much wider reach than government labs do for testing. So they were engaged, they were consulted, the process was established, and private labs contributed a great deal to the H1N1 testing. For SARS-CoV-2, private labs were not allowed to test until the middle of March. And once they've started testing, they've been contributing a great deal to people. Well, they could do more if there still wasn't this requirement for only certain categories to be tested. So for example, other than SARI patients, you couldn't test anybody till May of 2020. Even now, the amount of information that you have to provide for people to be tested is still a deterrent. But I think there's one other area of diagnostics that I would like to explore, which I've got in the next section as well, but maybe I'll bring it up here. And that is the quality of the testing and how important it is for countries and country managers to think about that. India has had a huge focus on essentially self-reliance, on making its own diagnostic tests, making its own ventilators, making its own PPE, because these were things that were in short supply during the lockdowns because supply chains were international. It became an issue to get them. The problem that we are seeing today is that while manufacturing and other things have been ramped up for diagnostics, the quality remains an issue. The standards for validation remain an issue. So I think in addition to strengthening manufacturing capacity, you also have to strengthen regulatory capacity and processes. And that's something that policymakers frequently do not appear to be willing to acknowledge. So that's the first part about not developing capacity for testing. The second one about channeling political capital, I'm beginning to wonder whether that's even feasible, because what we've seen, we are all health providers in a way. We can see a clear path to what needs to be done, but we seem to be incapable of getting our political leadership to recognize that and act on it. I recognize that politicians have many competing requirements, many pressing things that they need to be doing, that economies are important, and the health of the people matters if it supports the economy. But I think for the narrative to change to one where we can share information, where we can work together to address a global problem in the way that it needs to be addressed without placing hindrances on the way is something that I think people a lot smarter than me need to be thinking about. I know I've tried to communicate with people, and if you're within the medical ecosystem, people get what you're saying. You talk to political leadership, frequently the response that I get is, yes, we understand, but we can't necessarily act on it. And I don't understand the reasons for that inaction.
Professor Kang, the question I have now, so many questions, but they relate to the second, third, and fourth presentation.
Sure.
So before I let you start the second, third, and fourth, I want to ask you a very short question. Is all the services from testing to cremation free of charge, both in public and private facilities in India? Or
So,
state?
no. In public facilities, testing is free and medical care is supposed to be free, but frequently there are requirements for drugs, consumables, etc., that are not available within the public facilities. So families will be asked to procure them. And cremation has a cost associated with it. In private facilities, everything has to be paid for, but the government has set caps on the prices of certain testing certainly, but also on certain kinds of care that is to be offered by designated COVID care hospitals.
Thank you. This is something we should learn. In India, majority of the healthcare facilities are in the private sector, but they have barriers to provide service and access to service, particular financial barriers. In Thailand, majority of the facilities, especially in the provinces, belong to the public sector. But for us, all services from testing to cremation are paid by the universal health coverage, no matter it is public or private. It is legally incorrect, illegally wrong, even in the private sector, to charge anything to the patient. They have to charge based on standard price to the National Health Security Office. Of course, there are challenges in implementation. And do you also include these free public services and vaccines, everything for the migrant? You have many migrants also.
So vaccines are free. In between, we had a little bit of an experiment for about 6 weeks where the government decided that states had to buy their own vaccines for people under 45, and that private sector could procure 25% of the vaccines that were being made in the country. And the private sector went after it, and with the supply very enthusiastically initially, but inflated the prices so much that the government came in with price control even for the private sector. And after that, uptake of vaccines by the private sector has dropped quite considerably. So the bulk of vaccine in India is free.
Thank you, Professor Kang. The question on commodity supply, the question on communication, which I noticed that they are included in your second, third, and fourth presentation. We have 40 minutes left now, so I would like to request you to make presentation on the second and third, okay? And
Sure.
I'll see how the question go. Please go ahead with the second and third response. Presentation, please.
Thank you. Shall we move to the next slide? So, yes. So the next part was about key challenges. And one of the questions that always comes up is, how do you operate in a federal structure? And in India, health is a state subject, but where policy is decided at the center, and the execution on all health-related activities has to happen by the states. There are some vertical programs, particularly disease control programs, that are almost entirely run by the center, but those are just a few. The National AIDS Control Program for tuberculosis, for vector-borne diseases, etc. Now, if you look at India, and in the colored map, you have the states of India, and if you look at case fatality rates, and you look at full immunization, you can start to see patterns. Each of the little blocks is a district, and you can see that some states have higher immunization rates than others. There are some states with higher case fatality rates than others. And if you had high case fatality rates from a state, you would think this is a state that has poor health infrastructure. Actually, it's the other way around, because a state that is reporting high case fatality rates in India tends to be the state that has better reporting systems. And states with poor reporting systems also have poor infrastructure, but don't report high rates. So you need to look at indicators in many different ways to try and figure out what is going on. And certainly we have learned that some states have done a brilliant job with trying to provide services for their citizens, as well as in rolling out immunization, while other states have struggled a lot. Next slide, please. Now, if we look at surveillance, and this is our Ministry of Health website that gives you a snapshot of what is going on in terms of numbers of cases. And this is from 2 days ago, where we were told that we had just over 200,000 active cases, and that we had just over 450,000 deaths, with 181 deaths having occurred the previous day. And the total vaccinations, as I mentioned, is edging up to 1 billion vaccinations by today. Now, the problem with surveillance, of course, is who does surveillance for infectious diseases in the country. And in our situation, we have the Ministry of Health and Family Welfare, and it has a National Center for Disease Control that has an integrated disease surveillance program that requires that there be a public health official, an epidemiologist at every district in the country that reports to them. What actually wound up happening was that the surveillance was taken over by a research body, the Indian Council for Medical Research, which does not itself run any medical institutions, and yet it became the body that was responsible for certifying which tests could be used, what the prioritization was for testing. And this resulted in multiple databases being created. The Indian Council for Medical Research had the testing database, and the National Center for Disease Control had the hospitalization database. And it was very difficult to link the two. Since then, we've started the genomic surveillance, which is a consortium of 18 laboratories now expanding across the country. They come under the Ministry of Science and Technology, and some of the institutions that participate in that come under the Ministry of Health and Family Welfare again. So this again creates complications, because if you want data on whether someone whom you've got sequence data on has been hospitalized or not, you can't match the various sources of data up. And when you add to this, trying to understand what's happening in terms of vaccination, whether somebody who has tested positive has been vaccinated or not, it becomes even more complicated than that. So if I was to summarize it, surveillance varies by state. And if you try to look at it at the national level, it becomes really, really complicated, except for these kinds of headline numbers that are reported by the government. So that makes it very difficult to make more granular decisions on control. Next slide, please. If we look at diagnostics, we have a national control laboratory. It's called the National Institute for Biologicals. It's in fact a WHO collaborating center for pre-qualification in vitro diagnostics. However, this has been completely ignored, and instead the Indian Council for Medical Research was designated by the regulator. The regulator is in charge of the National Institute of Biologicals, but they designated the Indian Council for Medical Research as the nodal agency for approval of diagnostics. This was expanded to a range of other government-controlled laboratories that all use their own protocols for certifying tests for use. So that became complicated. And to sort a way out of the mess of different quality standards, different approaches to diagnostics, a new program was started by the Ministry of Science and Technology called INDEX. And this spoke to what the government was trying to do, which was to indigenize diagnostics as much. Most high quality diagnostics in India are imported from other countries. Most diagnostic platforms for biochemistry, for clinical pathology, for microbiology are imported from other countries. And the government decided that through this INDEX program, it would like to focus on indigenization. So it's essentially around creating an ecosystem so that there is sufficient supply chain to make high quality diagnostics, and then a pull factor to be able to sell these diagnostics in the private sector, starting with SARS-CoV-2 and hopefully expanding elsewhere. So far, INDEX has been in existence for a year, and they have come up with good products, but the problem is that the market for testing got saturated early. So now you're trying to break into a market with products that might not be sufficiently differentiated to offer any kind of significant advantage over existing testing strategies. So while the principle is good, the execution is still a challenge. The next slide, please. Drugs have been a complicated story. India is the pharmacy to the world. It's very good at making generic drugs, but we have all kinds of issues ranging from our ministers promoting drugs that are developed based on traditional systems of medicine and have no evidence to back their claims for prevention or disease, or trying to promote a message of strong indigenous development where you have drugs that have been developed by government agencies, such as the 2-deoxy-D-glucose, being promoted by the government. We also have the opportunity for existing drugs to be given to make a labeling change based on very limited clinical trials. And in the case of favipiravir and another drug called itolizumab, this is what happened. Small trials, 150 people, were used to support an application to the regulator, who then approved them for the use of SARS-CoV-2 based on data that might not have been accepted in other parts of the world. Part of the reason for that is that our Drugs and Cosmetics Act is old. It's from 1945. And even though we had new clinical trial rules that were approved in 2019, the language that we have allows for a lot of leeway that can be interpreted in many different ways. And that has resulted in supporting companies to make these claims for the use of their existing products based on very limited data. And that, of course, led to very irrational therapies being used across the country. Next slide, please. Oxygen was something that came up, again, very graphic images. And I'm actually on a committee that was mandated by the Supreme Court of India in response to the oxygen crisis to look at how the government was performing. And what we found was that was really interesting. There is no shortage of oxygen in India. It's just in the wrong places. So if you have just 2 or 3 places in the country that are capable of producing liquid oxygen, and you need to be able to get it across the country, crossing multiple state barriers, you need a coordinated system at the center so that there is no restriction on movement. What we had in India was supply that was adequate, but hijacking of oxygen containers as they were being transported across the country. So supply chain, logistics, and transport is absolutely critical to make sure that the oxygen is where it needs to be. There also needs to be thinking around storage facilities and the cost of maintaining these storage facilities as opposed to other approaches. One thing that came out very clearly was that a lot of places were hoarding oxygen, and a lot of oxygen was being wasted on people who didn't really need to be on oxygen. So when you look at it holistically, you can then think about what a distributed system for oxygen could look like. What is the level that you need to have for facilities and supply at different levels of care? And we now have a much more rational policy that is in place, where which places need PSA plants, which places need storage facilities, and what is it that you can do with downstream use of oxygen concentrators at home facilities. Hopefully, we will never need to see this kind of situation again, where you have volunteers who were providing oxygen to people who couldn't get it from hospital facilities. The next slide, please. When it comes to vaccines, vaccines are an Indian success story, edging up to 1 billion doses being distributed now. The main vaccines that we've had in the country are Covishield, Covaxin, and Sputnik V. Covishield, 88% of use in India, Covaxin just over 11.5%, Sputnik somewhere around 0.1, 0.2% of all the doses that have been given. If you look at the figure at the bottom, the graph, that is information management system called COVIN, which is an electronic system for registration and monitoring of vaccines being given in the country. And this had some initial teething issues because it was available only on smartphones and in English. But many of those issues have been sorted out now. And quite frankly, if you need to give 1 billion doses in the country, you do need an electronic system of some sort. As you can see from the top of the slide, there are over 40,000 sites that are giving vaccines, and about 38,500 of those are in the public sector, and less than 2,000 in the private sector. The next slide, please. For future vaccines, the Zydus Cadila vaccine has been approved in India, so 4th vaccine that is approved, but it hasn't been introduced into the program yet. There are a lot of vaccines that are at various stages of development. These are all the vaccines that are in clinical trials. Down at the bottom are 2 live attenuated vaccines that were early to start, but have progressed more slowly than other vaccines. And for children, as of yesterday, we have 2 vaccines, or day before yesterday, we have 2 vaccines approved for use. Covaxin, the inactivated vaccine, and Zycov-D, which is a DNA vaccine approved for children over 12 years of age. None of these are currently recommended for use in children at the moment. So then, shall I stop here or go on through the rest of the slides?
Professor Kang, in light of the time, and I see that you have just a few
4 more
slides left.
slides. Yeah.
So
I can
why don't you
finish
just finish it? Yeah, please.
Sure. Let's go. Next slide, please. Right. Media and communications. I mentioned the migrants before. And, you know, there are good things and bad things about the media. The rumors, the fear mongering, the scaring of people is obviously one part of it. The other part of it is having political leadership step up and talk about what really needs to be done. And in many ways, I think science journalists have really grown a lot in the past year. Next slide. When it came to communication specifically about vaccination, India worked with the UNICEF to make a very good document, 88 pages of communication strategy, very nicely designed. Unfortunately, the problem was that early on, at least, it didn't have a lot of penetration, and a lot of inaccurate information began to circulate that then required even more effort to counter. It's also been a problem that, you know, while we've tried, the government has tried very hard to communicate well, but the basis of some policy decisions have been unclear. We've discussed some of the issues around, you know, how do you make a decision on who tests and why you test? What kinds of drugs are used? When vaccines should be given, to whom should they be given? I think if we had greater transparency in policy making, overall communication around COVID-19 would have been stronger with more buy-in from the community. Next slide, please. I mentioned Kerala several times, and again, related to communications, there seemed to be this huge sort of effort to say that a lot of what was happening in India, the lack of control, was because a couple of states were not doing a good job of controlling COVID. Now, when you take a health message and you make it into a political message, this can become a problem, and it did. Because the states that were reporting high numbers of cases were the states that actually had the best reporting system, were doing the least under-reporting, and were not doing too bad a job of control of the pandemic. However, the government chose to target them, and that builds mistrust. Next slide, please. And I think that's my last one. Okay, so if we look at Kerala today, this is a state I've come back to several times. They had 7,000 cases on 12th of October. However, they don't have a healthcare system that is overwhelmed. They have plenty of ICU beds, plenty of ventilators. They have the lowest case fatality rate in the country. The country is at 1.3%. Kerala is under 0.6%. It's been reporting 50 to 60% of cases in India since July, but its healthcare system isn't overwhelmed. So if we talk about the lesson that we had considered at the beginning of the pandemic, which is flatten the curve, they are one state that did a good job of that. They're currently at 93% of their adult population vaccinated, 70% of total population vaccinated. And that's what's contributing to the 85% seropositivity in adults, which I had mentioned previously. So it is possible to do good things even within a federal structure. But overall, I think because we had a bad time in India during the second wave, we actually are in not too bad position today. We still need to be watchful. We still have a lot to do, but I don't think that in the absence of a variant, we will see the situation that we saw earlier in the year. So I'll stop there and I'd be happy to take any further questions.
Thank you so much for the excellent presentation. The three fellows, please send your question to my private chat. I'm waiting for it. Okay. While I'm waiting for it, I will ask some questions that I got to Dr. Kang. First, India prohibit export of vaccines. So COVAX, it is in trouble.
Yes.
It rolled out only 17% of its 2021 target until now, from January until now. When do you think India will allow Serum Institute to supply COVAX? Second, okay, you address this question first.
Okay, so I think very soon. We are in a situation today where we are giving out 5 to 7 million doses of vaccine every day. And Serum Institute is manufacturing more than 200 million doses of vaccine every month. So India is unable to absorb Serum's full capacity. Last month, 300 million doses worth of bulk was sent from Serum Institute, not last month, this month, was sent from Serum Institute to AstraZeneca. So it will be sold as AstraZeneca, but it's actually Serum is making the vaccine and providing it to AstraZeneca. So it's already started and it will amplify in the future.
So this means that India does not have enough formulation and fill capacity.
It does. No, there is plenty of fill finish capacity, but AstraZeneca has an agreement with Serum that Serum will make bulk for them. It's like Johnson & Johnson making bulk in South Africa or doing fill finish in South Africa.
And they fill and finish somewhere else?
Yes.
Okay. Thank you so much. My second question, do you think that your federal government has been doing well, doing okay, allowing election, allowing very popular public events, which was claimed to be the cause of the huge outbreak?
No, obviously from a public health perspective, at a time when you've just begun your vaccination program, that is not the time to allow for congregation of people, which is exactly what happened with the elections and the pilgrimages. So absolutely the wrong decision to have made at that time.
Now the question from the audience. We all know that one state of India is like one country, like one Thailand. And all the small district that you show is like one province of Thailand in terms of population. So you have state government that has independent responsibility for health services, and federal government. In this situation of serious pandemic, do you think that the federal government should take over everything, or this kind of relationship so far? Do you think they are okay?
I think for the oxygen, it made a difference when the federal government took over everything, because states were blocking supply to other states that were badly affected. But by and large, the federal government does a one-size-fits-all for most things. And actually, state governments know better what the situation is on the ground, which are the areas of weakness and strength that they need to target. So I think leaving health with states is not a wrong decision to make for most things. Occasionally, where supply is limited, like for vaccines, like for oxygen, I think it makes sense to go for a centralized structure.
I understand that in terms of decentralization, security issues are exempted. Whenever there is a national security issue, the federal government should take over. Why not in this case?
I think because a lot of execution here relies on the ground situation, and you don't necessarily have the central government having the relationships that allow it to execute well. So for example, if you look at a state and you look at the service providers in tribal populations, you frequently have non-governmental organizations that are responsible, and the local administration knows about them, whereas the central administration might not know about them. So if you want to execute things on the ground, you need to be closer to the people that you serve. In terms of policy, yes, it makes sense that the broad remits of policy should come from the center, but execution should be a local function.
Dr. Kang, please advise me. I want to travel to India badly. When will India open to me to travel there without quarantine? And I want to make sure that I'll be safe as well. So how much distancing, mask, and hand washing the Indian are practicing now?
So masking out of doors is well, indoors in public spaces and outdoors is a requirement. In terms of the quarantine, if you are fully vaccinated and get your PCR tests done, fully vaccinated with any of the WHO vaccines, there is no requirement for quarantine anymore. You just have to get your testing done prior to travel and after arrival. So I think that part of it will be all right. Are you at risk? We have festival season right now and for the next 6 weeks. So I think this is a time where you shouldn't be going into crowded spaces. The government is trying to limit crowds by saying that all of these events should be symbolic. But of course, in India, even a symbolic event can become quite crowded. So that's the only caution that I would advise.
So don't go to crowded area.
Yeah.
It's very difficult because in India,
everywhere is crowded.
Yeah. If you're in the big city, it's very difficult to avoid. But if you go outside of the city, then it's different. There's a question on your vaccine coverage now is only 900 million doses and covered around a bit more than 1/3 of the population, fully covered. What is the barrier to achieve, higher vaccine coverage? Or because you see you have very high seropositive prevalence, so you are not focusing on vaccination anymore?
We are definitely focusing on vaccine. That's why we are giving out, as I mentioned, 5 to 7 million doses of vaccine a day. It is possible to get closer to about 10 million, and this has been achieved on multiple occasions, but I think 5 to 7 million is also not too bad. And given one of the things that we did early on was extend the gap between immunization to 12 to 16 weeks. That results in a pretty high first dose coverage, and the second dose coverage has been slower to catch up. But I do think that the bulk of our population is protected now, and every day that number increases. What will happen ultimately is our immunization program, at least from routine immunization, has been capable of reaching about 90% of people. The last 10% is the challenge. And we are getting close to the point where, at least for the first dose, that 10% mark is going to be where we will need to expend a lot extra effort to make sure that people get immunized.
Well, you make me feel happy. So I should plan for my trip to India as soon as possible. Traveling around India has no limitation, right?
No, there are, it's opening up more and more, and international flights will be allowed from next month.
International flight will be allowed next month.
There are already international flights, but they are under special bubble arrangements.
Oh, I see.
And the full opening up to international flights will happen next month.
The same as Thailand.
Yeah.
But we still limited, we still limit to just maybe 10, 15 countries in the initial month, and then gradually expand.
Yeah, we've already got more than 15 countries, like flights to the UK, Middle East, etc., all already operational from India.
Including Thailand?
I don't know. I'll need to check and get back to you on that.
Okay. One issue I would like to ask is about ivermectin and favipiravir.
Yes.
The federal government of India stopped recommended since June 8th. Why in Thailand there are huge pressure to use ivermectin, but still not in our guideline. But we already use hundreds of millions of doses of, not hundreds of millions, maybe tens of millions of doses, courses, not doses, courses of favipiravir. Can you share with us your experience?
I don't think either of them work. I don't think either of them should be used. Wherever they have been, the data that led to any recommendation for either favipiravir or ivermectin was flawed. And quite frankly, I don't think either drug should be used. So I'm really glad that they are not in the Indian guidance. If you want to do a clinical trial, that's fine. And that's what we've been recommending for everything. If you can do an appropriately sized clinical trial and generate the data, then certainly use any drug where we don't have proof either way. But so far, I haven't seen any trial data that convinces me that these are drugs that should be used.
How about molnupiravir?
Molnupiravir is a bit stronger, but still it's not one that I'm going to jump for immediately. There are trials that are ongoing in India, and Merck has licensed 2 companies and is licensing a third to produce molnupiravir in India. So I don't think supply will be as much of a limitation. India had started trials with molnupiravir and then discovered that there were differences in the definitions that were used for what was considered moderate disease. So what was labeled as moderate disease in India would have been considered severe disease in the US. So those are now being modified, and we will have readouts from those studies soon.
We have 5 more minutes. I have still several questions. One of the questions that I have in mind all the time, I learned from our diplomat in India, Thai diplomat in India, who got infected. And they went to the private hospital to get tested. They said they pay only 400 rupees for RT-PCR, which is about $5. But in Thailand, if you go to private hospital and you don't use the public financial facilities, you want to jump the queue, you want rapid, you want good services, you want to pay by yourself, it can be up to 100 or more US dollar. So why your service is so cheap?
It's because the government has put a price control on what can be charged by private laboratories. It actually varies by the location where you get the test done. So the pricing has been decided by states.
Does this cap resulted in long queue? And if you want to jump the queue, you have to pay extra. Does that happen?
You can't. So there is no shortage of testing capacity now. There are plenty of labs that can test. The labs are, one of the problems with setting a price cap is that the price cap means that you will buy cheaper tests, which are lower quality tests. So I think the price cap is not necessarily the best idea in the world, but my own hospital loses money on the testing because we insist on using higher quality tests and the test costs more than we can charge for it. But we've decided that we are going with that route. Not every hospital has decided to do that, and there are some cheap tests available which are not good quality.
Wow. Time flies. Professor Kang, let me ask you last question. If there is anyone who want to get more information directly from you, can the Secretariat first share your PowerPoint slide? Second, yes. Send an email and allow your email address to be shared with those who are interested to communicate with you?
Yes, to both.
Thank you so much. You are so kind. I hope I can see you in person in the next few months. I have asked the regional director that please invite me to India as soon as possible. I miss it so much. And November, December, and January are the best months for us who don't like hot weather. I hope we can be there in the next few months. There are several things that we need to discuss within our own region. I would like now to hand it back to the moderator for this session to end and close this session. Moderator, please.
Thank you, Dr. Suwit. And I just want to summarize what we have learned from these sections, 1.5 hours. I think we already learned that zero prevalence of Indian population for COVID-19 is very high at the moment. It's about 79% in some states. And that is very important information for us because in some states that has very high vaccination rate, the case is still happening like in Kerala. So we learned that this COVID-19 is still going on, and probably in Thailand in the next few months we will still be in very similar situation. And we learn a lot from lesson learned that you gave to us. I am especially interested in the indigenization of diagnostic tests, which Thailand can learn from that also. And before we close, I would like to thank Dr. Suwit Wibulpolprasert and Professor Gagandeep Kang for your excellent presentation and discussion for us. Thank you very much. I wish that Professor Dr. Suwit aims to go to India will be fulfilled in the next few months. Thank you.
Well, thank you so much. And thanks to Professor Suwit and to everybody an invitation to come visit me.
Thank you. Goodbye. Thank you.
Thank you.
Bye.